the YouTube. We will be starting our session immediately. Give us a couple of minutes more. Technical team, Joe, are you there? Dr. Joe, are you there?
Yes, sir.
There is a question in the chat box asking whether do we have any certificate of online participation? I guess this program has a certificate of participation. Am I right?
Correct, sir.
Please answer that question personally or to the chat box that this program has a certificate of participation.
Sure, sir.
Good evening. Once again, please let us stabilize the Zoom. More than 200 people in Zoom and YouTube. Is that stabilized? Joe, let me know. As soon as the YouTube is stabilized, we'll start today's session.
We can wait another 1 minute, sir. YouTube is also stabilizing.
Dr. Naveen has asked in the chat box how to obtain the certificate. So you want to answer that also, Dr. Joe? Please do that as the class proceeds. Okay.
Sure, sir.
Eight, not 4. So is it stabilized? Technical team, please comment. If it's stabilized, we can start the proceedings.
Yes, sir. The crowd is stable. We can start, sir.
Joe, please look at the chat box. There are many people asking how to join the team of online dentistry. Can you email us? I
think Binu, that you are going to mention it at the end of your presentation. Those people who are not our group can be done. That will be done, right?
All right. We'll cover that at that time. Yeah. Can we start? It's 8:04. Maybe 1 more minute. We'll just wait till 8:05. It's 220, 230 people in Zoom. If it's pretty much stable, we can start.
It's stable, sir. It's 8:05. We can start, sir.
All right. Thank you very much. Good evening, one and all. Thank you so much for coming in on a Sunday evening on this topic, OPG. Let me introduce myself, Dr. Binu Abraham, CEO of Online Dentistry. We, with Dr. Jobby Peter, we together started this firm called Online Dentistry with a motto, redefine dental education. 2007, we did that. And then we conducted so many programs all these years till date. You can see the statistics there. We have almost 15,500 people in our platform at this point of time. Myself, Dr. Binu Abraham, orthodontist practicing in Kochi for the last 22 years. And me, with my partner, Dr. Jobby Peter, Professor and Head, former Professor and Head, Malabar Dental College, Department of Pediatric Dentistry. And he is the academic head of online dentistry at this point of time. We have almost 10 centers all around India at this point of time, but all our offline courses are suspended at this point because of the pandemic. Let's hope and pray that we get over this at the earliest. All the offline courses will be started as soon as this pandemic is out of our way. Let's pray. Now, at this point of time, we are doing webinars, online programs. Some are free webinars and some are paid webinars. 1 hour free webinar. The one you are attending at this point of time is a 1 hour free webinar. And then we have paid webinars, 3 to 5 hours, even 6 hours, even 7 hours. Last Sunday, it went to 7 hours on specific topics. All that will come in the particular WhatsApp group you are in. So please make sure that you are in one of our WhatsApp group so that you get all the updates of the coming up programs. The coming up programs, immediate coming up programs, next Sunday is a big program about unconscious patient in dental chair. We have programs about local anesthesia. We have programs about orthopedic movements at young age, but that unconscious patient in dental chair, the third one on the list, do not miss that. World-renowned speaker, Dr. George Paul Sir, oral surgeon, is going to talk about what will you do, how will you manage an unconscious patient in the dental chair. God forbid, let it not happen, but if that happens, Sir is going to explain about that. Then panoramic radiograph, that's today. CBCT, we already had a 1 hour free webinar. We are coming up with a 1 full day program on CBCT for exclusively those people who are interested to go one step above. And then we have a mouth breathing symposium coming up, wherein I am going to talk about the 7 to 8 clinical indications. 8-year-old, 9-year-old, 10-year-old, you see some clinical features, note it down. Please explain it to the parents. Some clinical indicators, those are very key indicators which you should not miss for a mouth breather, for a sleep disturbed person. And then Dr. Jobby, it's a symposium. So then Dr. Jobby is going to come up on how to deal with mouth breathing per se and the problems with mouth breathing. So do not miss that also. Then orthognathic surgery, we have a program coming up, but by none other than Dr. Sherry Peter, one of the finest oral surgeons you can meet in Kochi. So Sir is going to come up with orthognathic surgery part and he's an orthodontist come orthognathic surgeon. So he's going to explain exactly at a young age how to identify a problem and how to refer it nicely. That's Dr. Sherry Peter coming up soon in our platform. A big announcement is that online dentistry got associated with Lincoln University, Faculty of Dentistry, Lincoln University, Malaysia. We are now together. Many of the programs coming up are associated with Lincoln University so that you are eligible for an international certificate from Lincoln University, Malaysia. So please follow us in our WhatsApp group, Facebook, YouTube, wherever you are there. Please follow us so you will get to know which all programs you get an international certificate also, because the affiliation is already done and it's happening. Now, all those who are still not in our WhatsApp group, please put personal WhatsApp to one of these numbers, 98470-32 or 94463-21220. please put a personal WhatsApp. We will add you to one of the WhatsApp group we are in so that you get all the updates of the coming up programs. That's it. Now it's my duty to introduce the speaker of today's program, Dr. Eldo Koshi. When you talk about Dr. Eldo Koshi, a good friend of mine for the last, 15 years, sir? Good friend of mine. All I have to say is, I quote, unquote, Sir Albert Einstein. A genius is a person who makes complicated things simple, unquote, Sir Albert Einstein. Sir, we have Dr. Eldo Koshi as our speaker today, one of the finest prosthodontists I have met. He's going to talk about so simple stuff, which even a final year dental student is going to appreciate today. That's what I like about Eldo Koshi. Now, to talk about his credentials, is a huge list, but I can't go into all that. He's the fellow of American Academy of Implant Dentistry. He is in the board of FCDP UK. He's editorial of Kerala Dental Journal. And of course, he is the former head of the Department of Prosto. So we are having a personality here who is capable of delivering a topic of this kind in the most simplest form possible. Over to Dr. Joby to introduce the moderator of today, Dr. Utkal sir.
Good evening, everyone. Myself, Dr. Joby Peter, Academic Head, Online Dentistry. It's a great privilege to introduce Dr. Utkal again in this platform because he had come last week with a major program on CBCT. At that time, I have introduced you about him. I don't like that conventional way of introducing with a professional pedigree and all. Let me tell you, he is a person whom you should meet at one point of time. In advanced digital dentistry, if you want to march ahead, he is a person who you should meet, and his lectures are amazing. Why I say is he is so down to earth to teach, to preach, to advise you what is the best and how you should go ahead. That's a uniqueness about him. One simple example, let me tell you, when we programmed this OPG, we never thought about creating a moderator because it's everybody knows about it. But when we went in depth about this OPG, we realized that we need somebody to be there who has to be a specialist in this, who can guide us and moderate us. And when the last moment itself, when I requested Dr. Utkal sir, can you be there? Are you be free? He said, Joby, I am there for you. I will be there. When should I come? That simple and genuine and wholeheartedly, we welcome you. The team Online Dentistry welcome you for the effort you have put last week, plus entire week you are with us on making this program. And thank you so much for coming it. And over to Eldo Koshi sir, you can start the proceeding. Thank you so much for both the speakers and the moderators to be with us. Eldo sir, you can start the sharing. Yes, sir. We can see the slides, and I think you can make it to full screen and you can go ahead, sir. Sir, your voice is not the visible. I mean, here, your voice, Joe, can you look into the map? Voice is not.
Yes, sir.
And can you make it to full screen, sir? It's not full screen. Can you make it to the full screen, please?
Elder Koshi, sir. So can you speak, sir, now? So there seems to be an audio issue, sir.
Should sir go back and come back, come again, Joe, and the.
Let me just try that, sir. So do you have a speaker connected, sir? Elder Koshi, sir, we are not able to hear you, sir. So do you have a speaker? Yeah, no, much better. Yes, sir, we can hear you now, sir.
Okay. So shall I proceed?
Yes, sir.
Yes,
Can
please.
you make it to full screen, sir?
Right. Good evening, one and all. My name is Eldo Koshi. I'm a prosthodontist practicing in Cochin, in Kerala. I do implants as well, but I enjoy doing general dental practice more. The reason is that general dental practice exposes us more to the common dental needs of the patient than a specific needs that comes in a specialist dental practice. I've been practicing for about 21 years now, and like any other dentist, I used to refer for OPG to a distant radiology center. And I rarely used to examine the radiograph that I get back from the radiology center. I used to rely upon the reports that they provide. But of late, I bought a OPG machine, and then because of that, I was forced to learn the smallest aspects of taking an OPG. I had to learn about the machine, and I also had to learn about the importance of positioning a patient in the OPG machine to obtain a good quality radiograph. And also, I started analyzing my own radiographs that I've taken and started analyzing the mistakes and the things that is displayed in the radiograph. The reason for this presentation is not because I'm an expert in the subject OPG, but because of some real life experiences and some remarkable interventions I could make in the lives of people thanks to OPG, which would have resulted in a massive disfigurement and a catastrophe in the lives of my patient. I will mention about a personal experience of a family member uh, because of which I could save a massive disfigurement of a family member towards the end of this program. I wish to mention that I'm not an expert in radiology and have limited technical know-how about the machine. And I wish to thank Dr. Utkel, an eminent radiologist whose lecture I attended last week, who is our moderator to answer all your technical questions regarding this, and Dr. Joe, and also Dr. Binu and Dr. Joby. I cannot
Sorry to interrupt, sir. Sir, your screen share has been stopped, sir. So
Yes.
could you please share your screen? Yes.
It's on. Can you see it now?
Yes, sir. It's visible, sir. So you can go into the full screen mode now, sir.
Okay.
Perfect, sir. Please continue, sir.
So let me thank God for this wonderful opportunity to present this topic before you. A good clinical examination should start with a soft tissue examination, and then we should examine the temporomandibular joint. We should palpate the joints, and also we should see for any early contacts. We should see for the occlusion of the patient by seeing the early contacts, or if there is any functional interferences, etc. Then it should be followed by tooth examination, the hard tissue examination, followed by a soft tissue examination, meaning the periodontal examination and getting the periodontal scores. Then comes our radiographic examination. If you check the meaning of the term panorama if you Google that, you will know that it means that it gives an unbroken view of the whole region, or it means it is a wide view. So orthopanomogram, it's called also called as OPG, otherwise panoramic radiograph. Some people tend to call it as PAN-O. Some people call it as pan-oral images. So our dental arch is not in a straight line. It is in a curved shape. So it is generally, OPG takes an image in a curvilinear fashion. It is just like taking a photograph of the anterior region and two photographs on the lateral side and joining them together, because of which we may get a blurring of the premolar region or an overlapping of the images of the premolars usually. Definitely, the advent of CBCT is revolutionary in the industry, but the importance of OPG still remains. Why? Because OPG, the greatest advantage is that it gives both the arches, the upper and the lower arches, in one single image. Not only the dental arches we also get the para-dental structures in this image. So that's a definite advantage of an OPG. OPG is just like looking into a whole loaf of bread, an unsliced bread. So you don't know what is happening inside, what is there inside the bread. But we can get a fair idea of the dental arches, the mandibular region, the maxillary region, and also the temporomandibular region. But CBCT, definitely it's an advantage because, as we had heard from Dr. Utkel last week, it gives slices of images of that particular region, and you can see it, visualize it three-dimensionally, axially, coronally, and also sagittally. So that's definitely a great advantage. So OPG means you get a fair idea, a general idea of the question, of the subject, and CBCT you can get in slices. But there's a drastic difference between OPG and CBCT. The cost of an OPG generally is from 500 to 700, whereas the cost of CBCT is 5 times that of an OPG. The radiation that we get from CBCT is 8 times than that we get it from one OPG. 8 times OPG is equal to 1 CBCT. So we should have a good understanding of the anatomical structures in order to interpret a good radiograph. So we'll just go through the relevant anatomical structures very quickly. This is the nasal bone, infraorbital foramen, the zygomatic arch, and the zygomatic process of maxilla, otherwise called as jugal crest, the nasal bone, the anterior nasal spine, the incisal canal, the hard palate, the greater palatal foramen, the pterygoid hamlet, nasal septum. This is the vomer. Again, vomer, that's the hard palate. This is the maxillary sinus. You know, this is the incisal canal and the palatine process of maxilla. So we'll see how we can interpret this in a dentate patient in an OPG. So external auditory meatus is this, which is seen in the OPG here. So that's the head of the condyle. That's the glenoid fossa. This is the articular eminence of the fossa. That's the marking of the earlobe on both sides. That's the coronoid process. This is the ramus of the mandible. That's the angle of the mandible, body of the mandible. the mental symphysis, external oblique ridge, that's the internal oblique ridge. The hard palate comes here. And the image of the soft palate. This is the maxillary sinus. And this is a sinus buttress. Buttress is an elevation of the bone that sometimes is seen in the maxillary sinus. So buttress usually forms a difficulty while you do perform a lateral window sinus grafting procedure. So this is a buttress that is seen when you are trying to do a sinus grafting by means of a lateral window. So this buttress will form a difficulty in elevating the sinus membrane from the bony buttress. So you may have to do a two-window technique in order to perform a lateral window technique. So this can be ascertained. The presence of buttress can be ascertained from a good radiograph that you take. And this is the floor of the orbit. This is the nasal spine, which is shown in the OPG, like this. That's the nasal septum. And this is the lateral pterygoid plate. Nowadays, people are placing pterygoid implants. So you should know where the lateral pterygoid plate comes in an OPG. And that's a lateral pterygoid plate. This is the medial pterygoid plate, comes towards the medial side. That's the medial pterygoid plate. The mental foramen, the inferior dental canal, that's the lingula. This is the mental foramen. There is something we need to know about the mental foramen, which I'll explain when we explain about the OPG that we take in an edentulous case. So this is the inferior dental canal, which you have seen on the other side. That's the lingula. So this is a shadow of the tongue that we seen in an OPG. We are supposed to ask the patient to place the tongue, to press the tongue against the hard palate. Only if the tongue is pressed against the hard palate, then only we'll be able to analyze the apices of the maxillary root. And this is the orifice, the oral orifice that we see. So when I was a PG, I've done many cases of complete dentures, but I've never taken an OPG of an edentulous case. But once I started doing implants, we regularly take OPG of an edentulous patient. So we need to analyze how anatomical structures relate to in an OPG of an edentulous situation. So this is a bite block that you see. That's the external auditory meatus. That's the glenoid fossa. That's the head of the condyle. And if you see the maxillary region, there's a classification called as Bedrosian classification of maxillary volumes, which can be ascertained in from a radiograph, from an OPG of an edentulous patient. This shows the volume of bone in these maxillary regions. Here, he has classified the maxillary region into three: zone 1 and zone 2, which is the premolar region, and zone 3 comes at the molar region. So depending upon the amount of bone which can be ascertained from an OPG, yes, we can determine what kind of implant restoration we can give. So this is zone 1, this is zone 2, and this is zone 3. When there is adequate bone present in 1 and 2 regions, you can place an all-on 4 in the maxilla. Or when bone is present only in zone 1, you can give implants, vertical implants, parallel implants in the traditional implants in the zone 1, but zygomatic implants which comes from zone 2 to give a fixed restoration. When there are insufficient bone, when there is insufficient bone in all the three regions, then you can go for 2 zygomatic implant and probably a pterygoid implant. So this is called as quad zygoma. This is pterygoid implant. So all this can be ascertained by taking a OPG of an edentulous patient. All-on-4, which is very popular now, can also be, the treatment of all-on-4 can be decided if you take an OPG of an edentulous patient. You see this is the mental foramen, which is very high up, which is almost in the crest of the ridge. And you can see that the inferior nerve is so high up, very near to the crest of the alveolar bone. So in such situation, if the patient demands a fully fixed restoration for the lower jaw, then you can place 2 implants parallel to each other in the anterior region, and then 2 implants which are angulated at about 45 degrees. You can escape the mental foramen like this, and you can give a fixed restoration, which is called as an all-on-4 restoration. So this is the mandible, and it has got a coronoid and condyli process. So this is the coronoid process, as you see in an image, and that's the articular eminence. And hyoid bone comes below the mandible, and that's the earlobe. And this is the ramus of the mandible. That's the angle of the mandible, body of the mandible. And this is the image of the spinal column that sometimes would come in the image. This is the external oblique ridge. That's the internal oblique ridge. Hard palate. That's the hard palate. And mental symphysis. And that's the image of the tongue and the soft palate. That's the maxillary sinus. You can see that once a tooth is gone, the maxillary sinus pneumatizes and it becomes a huge hollow cavity. That's the lateral pterygoid plate, and this is the lateral pterygoid plate. This is the medial pterygoid plate, and this is the sinus buttress. That's the floor of the orbit, anterior nasal spine, the nasal septum, mental foramen, inferior dental canal, lingula, mental foramen on this side. So one thing we should realize about the mental foramen is that when we are in, the mental foramen is almost the middle region between the inferior region of the mandible and the alveolar crest. As we age and as the resorption proceeds over the alveolar crest, the mental foramen will start going up and up to a region in which the mental foramen comes over the alveolar crest. The importance of this is that, just by looking at it at a edentulous ridge, you may not know where the mental foramen is like. So, mental foramen can be located in an OPG. The technique, a simple technique, is to place an orthodontic wire in the premolar region, and then you can take an OPG and you can correlate where the orthodontic wire is to the mental foramen. Another important thing about mental nerve is, if it is so high up, if you place an incision to place an implant, what happens is you can sever the mental nerves and blood vessels, which can result in numbness of the lower lip. So this can be ascertained, the presence of mental nerve and the location of it can be ascertained by taking an OPG. And also, as I said before, you can place an orthodontic wire and you can use the existing denture as a guide. Usually mental foramen proceeds into an incisal canal by making an anterior loop. So if you place an implant in the anterior loop, also probably you may result in numbness of the lower lip. So identification of mental foramen is very important, so that you can place your implant 2 to 5 millimeter anterior to the mental foramen, thereby preventing numbness of the lower lip after you place an implant. So this is the anterior loop which can be identified in an OPG. And there has been a study where the mental foramen is. So we might generally think that mental foramen comes here in between 2 premolars, but there has been a study which says that mental foramen can be located in between the mesial cusp of the first molar to the premolar, to the first premolar. In between here, anywhere mental foramen can come. And if you place an implant in this region into the mental foramen, or if you cut through the mental nerves and blood vessels, it can result in usually transient and sometimes permanent numbness of the lower limb. So this is the inferior dental canal. You can see that the inferior dental canal is so high up in this OPG, which would necessitate nerve transposition. So this is the mental nerve. This is the cadaveric bone, and you can see the inferior alveolar nerve is so high up, so that if you place an implant at this region, definitely it can result in paresthesia and also pain in the lips. So you can transposition the nerve. This is the case of Dr. Soni Mevada, who is a surgeon in Kannur, who has transpositioned the nerve and placed implants there. So this can be ascertained by taking a good OPG, and that's the lingula. The problem with OPG is that there are many factors that can result in errors in an OPG. These errors can be due to an improper patient positioning, and it can be due to an artifact, which is also called as ghost images in an OPG. And there are very much chances of magnification errors coming in an OPG. So I place an implant, 3 implants on the right side, 3 implants on the left side in a patient, in the maxilla, and 3 implants on the right side and 3 implants on the left side of the patient. And then I took an OPG soon after the implantation procedure. And to my surprise, I found that all these implants, 5 implants are on the left side, only 1 implant is remaining on the right side. And you know, I was so definite that these implants were placed on the right, 2 more implants were placed on the right side. So I took another OPG after I placed a multi-unit abutment on this patient. And this time I realized that the patient was not biting on the bite fork properly. So this is a potential error that can happen in OPG. If the patient moves or the patient doesn't bite properly on the bite fork, and on the bite, there's a trough, which I'll be explaining soon. If the patient doesn't bite properly on this region, it can result on the bite fork, it can result in error. So successful panoramic image taking requires patient cooperation. So I recently learned that, you know, when you position a patient, you're not positioning the patient vertically. You will ask the patient to step a little bit ahead and to cling on to the handle that is provided. If you position the patient vertically, your head will not be positioned properly. So your cervical spine has to be oriented like this to get a good OPG. So the correct head position will be, the neck should be straight, the head should be tilted slightly forwards, the forehead should be tilted slightly forwards, and the chin should be slightly back. So this is a good head position for an OPG. There are light beams. There are 3 light beams that will guide the patient positioning. So, and there's a bite fork that the patient should bite on. There's a mid-sagittal light guide, which should pass to the mid-sagittal region, a Frankfurt horizontal plane orientation guideline, and a canine line, which has to go through the distal of the upper canine to position the patient properly. Here the patient has bitten too far forward on the bite fork. So all this can result in improper image. So we should always check the patient before taking an X-ray. If the patient, we have to remove the jewelry of the patient. Here the patient has not removed the necklace, so which has come in an image or in the OPG. And also you can see the presence of glasses in the image 2 and the earrings in the image 2. A good OPG should look like that. It should be a kind of little curve on the teeth, and the condyle should be in the same level. The image of the spine should not come in between the anterior region, and there should not be any overlap between the teeth. You should be able to identify the apices of the maxillary teeth. So we'll see some problems that can generally occur. It is in an OPG. You see that there's a reverse smile here, and the apices of the maxillary anterior, the maxillary teeth is not seen in this. That is because when the patient keeps their chin too high and the palate gets overlapped over the maxillary roots, and the apices of the teeth will be obscured by the hard palate. And this can happen when the patient bends their neck backwards. The apices of the teeth will be obscured by the image of the hard palate. The palate gets superimposed on the sinus like this. The solution is to ask the patient to tilt their head forward. Sometimes, if the patient doesn't push their tongue against the hard palate properly, there is an air space, a black space here, which will obscure us from understanding the image of the apices of the maxillary anterior teeth. So we should ask the patient to push their tongue against the hard palate while an image is being taken. Here you can see that the condyles are at the top of the image, and there's a sharp fin-like of image here. This is because the chin is too low on one side, and the chin is too low, and you can see a lead apron which is above the collar line. This is called as a smiley image because an exaggerated smile has come because the chin is too low and the patient is biting too far forward. It's called as a smiley image because the chin of the patient was too low. Like this, the head was too far forward and low. Sometimes this is called as a Washington Monument image. The spine comes in between the focal trough. This happens when the neck is bent forwards. This is called as a Washington Monument, when the patient bites too far forward on the bite block, and also the canine lacer is too far forward. Sometimes you will see an overlapping of the anterior teeth. This happens when the patient is not properly biting on the bite block. Sometimes there is ghosting and unequal condyle heights on the image. This is because of the tipping of the head of the patient. And you can sometimes see that the ramus is wider on one region, whereas it is shorter on the other region. This is probably because the patient has moved their head. And you can see that the teeth is wider on one side. Also because of the movement of the patient while the image is being taken. And generally we see a magnification in an OPG, and most of the images expand. So this can be ascertained by if you keep a ball bearing and then you take an image, you can see that the ball bearing is distorted. So we can calculate the magnification of an image by using a ball bearing. I'll just quickly go through this because I'm going to explain it in the image. What you can do is you can buy ball bearings from a cycle shop. Generally, it is a 5mm cycle ball bearing for an implant, magnification calculation. So what you do is, that the ball bearing is 5mm diameter. So you take an image and you directly measure the diameter of the image of the ball bearing that you get in a OPG. So if the image is giving a diameter of 6.4mm, you divide the 6.4 by 5mm, which we already know, which is the standard diameter of the ball bearing which you have bought. The magnification of this image is 1.28. So this is the magnification factor for this image. And what you do is you will divide the 6.4 by 5, which is 1.28. You write it on the template, which is kept over the image. And then what you do is you can draw two arrows and measure the distance that you get in between the arrows, which is 15.5, which is divided by 1.28, which is your 12mm, and that is the actual height above the mental foramen in this region. Likewise, you can get the measurement of the bone that is available, the vertical bone that is available above your inferior alveolar nerve. So another patient, what you can do is, he has got edentulous areas on both sides. So what you can do is you can place ball bearings on a wax on both sides, and you can go ahead with the measurement. So in this situation, you need to know the distance between the two teeth in order to plan for implant placement. So here, mesodistal measurement of the ball bearing is done, which is 6.2, as we had done before. By 5 is 1.24, which is the magnification of this image. So what you can do is, you can, after that, you can measure between the two teeth, the distance, which what you get is, you can record that. Also, the magnification which has happened vertically also you can measure, which is 6.4 in this image, and the magnification factor for that vertical measurement is 1.28, and the magnification ratio is 1.28 here. And you measure the height that is available below the sinus floor, divided by the magnification factor, which is 15.6, which gives the actual distance vertically below the sinus floor. So similarly, on the left side also you can do the same. So you can, why I've put this is, there is a difference in magnification on the left side and the right side. So here it is 6.2 divided by 5, which gives 1.24. Magnification factor is different on the left side from the right side. So you can again measure the distance in the image between two teeth, and the real width you can ascertain from this, and plan an implant. Why we need to do is, in an implant placement, we need to get between, we have to have at least 1.5 millimeter of distance between from each adjacent teeth. So this can also be ascertained by means of a good panoramic radiograph. So you can place your wax, your ball bearing on a wax sheet, but you should always make sure that the ball bearing is placed on the center, at the center of the ridge. So here a ball bearing is placed not on the center of the ridge, which can result in a distortion of this ball bearing. So what you can do is, you can make a RPD and a wax ring, and you can place a ball bearing inside this RPD, or a foam wax can be used, and the ball bearing can be placed in the center of the ridge in this foam wax, and then now you can take an image. Now you can see for the resorption that has happened. What I've done is, I've made a bite ring, and then I have placed the orthodontic wire on the bite ring and another on the integral surface of the bite ring, and I've placed a measured orthodontic wire, and then you can take an OPG, by which you can locate the mental foramen, and also you can measure the amount of resorption that has happened in this patient. Why? Because you can decide what kind of processes you require, because a bar overdenture would probably require about 18 millimeters of space between the alveolar crest and the incisor edge of the processes. Now I'm going to tell you some incidental findings which I found in my clinic after I started analyzing my own images taken in the clinic. So here I've taken a OPG for this impaction, and also this patient was complaining of some pain after root canal treatment, and I found a massive lesion underneath, periapically to this tooth, and there was slight expansion also of the bone. So I could, inform the patient. The patient was unaware of this massive lesion here, and I could send this for further investigation of this patient. And this patient had all the teeth here, and then surprisingly, I found 3 supernumerary tooth for this patient. And another patient, had all the lower teeth here on the right side, but another supernumerary tooth, and that was on the ramus. So for this patient, I had taken an image because he had a deciduous tooth remaining there and some mini caries lesion. So I took an OPG, and to my surprise, I found that there is a sclerotic bone on the left side, and then an odontoma here. Odontoma is a coalescence of multiple underrupted teeth, and totally we were unaware. The patient was unaware. There was no symptoms, and this was an accidental finding, and a supernumerary tooth here also. This patient had all the teeth there, but we could find 7 unerupted teeth, supernumerary tooth in this patient. We had taken OPG for this impacted tooth, which was giving some pain, and we could see a huge lesion distally to this impacted molar. And the patient of a sleeping, unerected, impacted canine. I'd taken an OPG because of a fractured implant, and then I could locate a osteosclerosis on the left side of this patient, and a huge osteosclerosis. This could probably be an osteoma, and a further investigation with a CBCT is demanded in this situation. This could be identified by a screening with an OPG. We had taken an OPG for this impacted tooth, and we could see a huge lesion here, and also the shape, hypercementosis probably of this tooth. An extraction would be very difficult in this situation, and a huge osteosclerosis on the left side of this patient. I did a research on the internet, and I could find an article in Dental Update which says that if you have more than 5 sclerotic islands, then it can probably point to Gardner syndrome. So this is referenced. Dental Update says that if you have more than 5 dense bony islands, a Gardner syndrome could be considered. Now, another OPG, I could find a radiopaque mass and somewhere overlapping the inferior dental nerve. An OPG was taken for deciding the vertical bone availability at the sinus region, and also here the missing tooth space. And surprisingly, I could find a radiopaque mass underneath the ramus of the mandible. I'm seeing this for the first time in my life after 21 years of practice. I've never seen a kind of thing like this. I thought this was an radiographic image of an artifact because he had worn a shirt with a button. And I asked him whether this has got a metal thing inside the buttons, and he said no, it's not there. Then I had sent him for a ultrasonic examination of this region, because on further discussion with radiologists, they said that this could be a huge stylolith in a submandibular gland, or probably this could be a tonsillolith. So he was sent for ultrasonic examination of this region. And then I could read that probably dentists can accidentally embark upon a carotid artery calcification. Probably if you see a radiopaque region in the level of C4, this can result in identification of the risk of a stroke for this patient. This is called as a phlebolith. And we can also probably identify the presence of osteoporosis of a patient if we see thinning of the inferior cortex of the mandible, and you can compare this image with the thickness of with the radiopacity of the ramus in this previous image compared to the thinness or the radiolucency that you can see in this patient. Another image was taken for of this lesion, but we could identify supernumerary teeth, 3 of them, and also a radiopaque mass, probably an amalgam or an extrusion of the sealer. And then, interestingly, this is a male patient who is a guitarist who had come up, who had a earring on his left ear, and who could not remove this image when he was about to take this OPG. And then I could find radiopacity on his right side. So probably I thought this is he's having a hearing aid. So I asked him, do you have a hearing aid? And he said, no, I don't have a hearing aid. And then on further reading, I understood that this is a artifact which is caused by earring, an unremoved earring on the left side. And usually they said that this artifact would be at a higher plane than the original earring. Then you see it on the opposite side at a higher plane. And then a beautiful lady patient who came, I took an OPG, and then to my surprise, I found all these wires here. And I asked her what this is, and she said, I forgot to tell you that I had undergone orthognathic surgery when I was young. And I took an OPG of mixed dentition stage, and then I realized that, you know, if the canine at this age, it is overlapping onto the distal portion of a lateral incisor, as you see on this image, it means that we need to be very cautious. This patient may need intervention in his young age to prevent a malocclusion being developed. Whereas this patient, if you see that, he is quite safe because this canine at this mixed dentition stage is away from the margin of the lateral incisor. So an OPG in a mixed dentition stage is very important. This patient came with a complaint of mobility of the anterior teeth. I took an IOPA, and then I found that there's a root canal treated tooth, and some portion is resolved, and she had a hit on this tooth by her child. So I was probably suspecting this. And then she said she wanted orthodontic treatment. She had already undergone orthodontic treatment, and can we do an orthodontic treatment after removing this, and can we place an implant? So I took an OPG, and to my surprise, I found that this patient had no roots on the right side. And I sent this image to many radiologists, and this could be because of a prolonged orthodontic retention. That's what experts say. And I'm seeing such a kind of image for the first time with no roots, and that too on one side. Left side is completely normal. This patient came with food impaction and pain. So I took an OPG. I found that there's an an IOPA. I found that there is a impacted tooth here and food impaction here, and there's also an impacted tooth on the left side. So since there are two impacted tooth, and I could see that this is very close to the inferior nerve, so I took an OPG, and to my surprise, I found that this patient had a huge lesion, which is related to the crown of this tooth on both sides. And then we sent him for an CBCT. We could find that this is a huge dentigerous cyst, and the patient had to remove both of them. And the surgeon was, fearing numbness on both sides. So if I'd taken an OPG before, I could have easily identified this, and I could have prevented him from going ahead with a massive surgery like this. This patient came up with pain on the right side. We saw that there's an impacted tooth with an IOPA, so we removed the impacted tooth. And later, this patient started coming to me for almost 2 years, saying that there is soreness. This is her term that she was using. There is soreness on this side. So I was, doubting there is a crown on this tooth. And then I took an IOP and said, your tooth is gone. There is no problem. Probably this is the crown that is, this tooth is the one that is creating a problem. And then she was still insistent. And then I took an OPG. I found that there's a huge lesion, that is involving the ramus of the mandible. Probably this is a OK cyst, and she's undergoing marsupialization at Amrita Dental College even now. And this patient came with a complaint of food impaction here. I tried to take an IOPA, and since it is high up, this tooth is impacted highly up. So I took an IOPA. I couldn't take a proper IOPA, so I took an OPG. And to my surprise, I found that there's a huge lesion on both sides. So I had to send this patient for further investigation. And he had to undergo surgery. And this patient came back thanking me for saving his life. If we had not identified by taking OPG at the right time, even this is very late, but at least now, then it would have resulted in a massive problem and disfigurement for this patient. This is a funny image that I found, once I took this image just because he had multiple full mouth rehabilitation with a crown and bridge, and I found that all this all these tooth were root canal treated. Once my assistant forgot to remove the spectacle of this patient, and then I got a funny image like this, a Michael Jackson kind of image. This image was taken to find that whether enough bone is there for an implant at this region. But even though these images are not up to the mark, but there's a principle called as ALARA, which is as low as diagnostically acceptable. If this image is diagnostically acceptable, in spite of all these artifacts, we should not reject this image, because this can present this patient to unnecessary radiation. So radiology in dentistry should always supplement and confirm clinical findings. We should always diagnose and treatment plan before we take an image, and then this should always confirm and supplement the clinical findings that we get. And OPG will always be helpful in post-treatment review like this, and immediate post-operative surgical OPG is taken. You do a prosthetic stage, you take an post-prosthetic OPG, and this can be kept as a baseline image. And when the patient comes for further review, and after 1 year or so, you can compare the bone loss or the bone present with this baseline image. And as I said before, OPG is a good tool for an initial screening, and it's a good tool for an intraoperative or an immediate post-operative appraisal of a surgical procedure. In the previous image, I placed an implant wrongly, and then I could immediately take an OPG. And with an IOPA, you cannot place an IOPA so far down. So an OPG is a good tool to intraoperatively find any mistakes, and then you've done, and you can rectify it immediately. And if you compare the dosage, OPG, the dose, the radiation is 2.7 to 38 microsieverts that we get. And if you take a full mouth IOPA, it is 8 to 10 times that of an OPG. And this was said by Dr. Utpal in his last Sunday's lecture. And the CBCT exposes the patient to even more of radiation. So minimal exposure to radiation is our goal, and it should follow, and it should give enough information, and you should know the needs, and you should weigh between the needs and the risk that you are exposing the patient to. Radiation risk is always dose related. We should always follow the ALARA principle, which is as low as radiographically achievable. And we should always select an imaging modality that provides necessary information at the lowest possible dose. And we should always justify the investigation that we have done. The National Council for Radiation Protection has said that the CBCT need not be used for routine investigations. And also, CBCT should be used only where a 2D image fails to provide sufficient information, or otherwise CBCT can be directly taken if you're planning guided surgery in an implant situation. And I would stop my lecture by a real life experience of a family member. He had flared teeth, and I thank God for his flared teeth. I took him to Dr. Joby. He's in a mixed dentition stage. And to my surprise, Joby doctor had asked me to take an OPG and a lateral step. And then to my surprise, I found that he has got a massive lesion, radiolucency, that is, around his follicular space of the erupting first premolar. He was 9 years old then. And we took a CBCT, and we found that it's a huge lesion that is, approximating the mental foramen. And we did a surgery, and you can see this in the CBCT slides that it's a massive lesion. It is almost involving it has eroded the cortex, the buccal cortex. So we did a surgery to enucleate the cyst that was around the follicular space, and we could find that it is a dendritic with unicystic ameloblastic changes in that. So, but for this image, we would have never identified this happening in this patient, and then it would have resulted in a massive, destruction and disfigurement of him. And I thank God that he had flared teeth, and Joby doctor, suggested to take an OPG for him and the lateral set. To conclude, for diagnosis, treatment planning, and post-treatment review, the preferred initial investigation is a 2D image, which is an IOPA or an OPG. 3D imaging, CBCT, should be used for further investigation of a pathology detected in 2D. And the lowest dose examination that will answer the clinical question should always be undertaken. OPG is a good screening tool in general dental practice. I would like to thank Dr. Utkel, who is very much here to answer all the technical questions related to this presentation, and Dr. Joby Peter and Dr. Binu Abraham and the technical staff, Mr. Joe, for giving me an opportunity and technically supporting me in this presentation. Thank you very much, all of you, for your patient listening to me. Thank you very much, and have a good night.
Thank you so much, sir. You are amazing, Eldo sir. You have done the limitation. You have done a wonderful presentation and excellent collection of OPGs for practice, which you told me when you came, and that is the discussion that we lead into this session here. It was a real life experience he told, and he said, Dr. Joby have cases. Why don't we present to general dentist? This is proof. It's like unrated, you can say. No script, no hidden. He has just explained his own experiences in a very raw format. It's up to you to criticize, up to you to say what you felt. If you have any doubts related to that, we have moderator, we have the great speaker with us. So you can put in a chat box. If anybody want to unmute yourself, raise your hand, I can unmute them. We can come live and talk and whatever. Please go back to your respective WhatsApp group, criticize us, praise us, please criticize us so that we can improvise next time. So I'm going to take up questions in our Zoom platform and YouTube platform. Sir, today we had around more than 550 listeners from YouTube and Zoom. That's an amazing number in this lockdown time. So I'm going to take up some questions from Zoom. And if you have any more questions that you want to do, you can put it on the chat box. One question: can you repeat? The how to measure the bone resorption in an OPG?
Okay. So what I've done is this is done to assess the amount of space that you get. You can clinically assess it actually, but since you're taking an OPG, we can again ascertain the amount of radiographically the amount of resorption that has happened. So what you do is you can make a bite trim as I had shown, and I'll go to that image. Just give me a moment. Yes. So what I've done here is I've come to the bite trim stage, and then I've kept a orthodontic wire here, another orthodontic wire on the intagular surface of this bite trim, and then this is measured. I've kept a orthodontic wire probably 10 millimeter, and then I've subjected the patient to an OPG. You can do the same if the patient comes with a complete denture. You can keep an orthodontic wire on the incisal edge of the complete denture. You can place another orthodontic wire underneath the complete denture, and even place a orthodontic wire somewhere near to the first premolar. Now if you take an OPG, you can know how much of space is there for your prosthetic rehabilitation. You can decide what kind of restoration is possible, both clinically and also radiographically. and this will also help in locating the position of the mental foramen, and which will also act as a surgical guide. If once you open up the flap, then you won't be able to know where your mental foramen is. So yeah, so once you open up the flap, sorry, it's gone. My screen sharing is gone. Sorry. So if you open up the flap, what happens is you have no idea where the mental foramen is. So what you do is, if you keep a orthodontic wire somewhere near the first premolar region and you take an OPG, then you'll be able to identify, where the mental foramen is in your radiograph. And also, once you open up the flap, you keep the same denture on the ridge, and then you can identify where the mental foramen is like.
Thank you, sir. Thank you for that elaborate explanation, sir. One question is, sir, I think it's a general practitioner who asked this question is, sir, do you still believe that you have to take an OPG before an implant, or should we only take the advanced protocol like a CBCT first?
Okay, so CBCT, as we know, it gives a lot of radiation than OPG. So the initial tool is to take a OPG, and then you can clinically measure the ridge, and only when you are in doubt about how much of space is left underneath the sinus or the ridge, or if you want to accurately measure the amount of space, the width, the height that is available for your implant placement, then only you need to send the patient for CBCT directly. Or as I said before, if you want to place an implant by a guided surgery, then directly you can send the patient for CBCT. Otherwise, if you can clinically ascertain the width and radiographically ascertain by means of a OPG, then you need not expose the patient to such high radiation as in a CBCT. And also CBCT is more expensive than OPG.
Another question is from Dr. Priyanka Kumar. Sir, how to put that orthodontic wire?
Or if it is a white rim, you can just melt the wax and push the orthodontic wire into the rim. If it is a denture, then you can attach this wire by means of super glue, and then later you can remove it off and then polish the denture and give it to the patient.
Fine, sir. Another question from Abhay Singh from Zoom is, can we decide that impacted tooth is buccal version or lingual version in OPG? Maybe that's what he is.
It's a little bit difficult to identify in a OPG, but probably the slob technique we'll be able to identify, whether it's easily, or I don't know. Probably Utkal will be able to answer it.
Dr. Utkal, can you please address to this as a technical question? In an OPG, we can't. It's a two-dimensional picture, so
Yes,
we can't take buccal or a lingual version. What could you suggest, sir?
Exactly. For any impact.
Sir, you are stuck, sir. Can you please repeat, sir? You are stuck. Can you please start again, sir?
Okay. Now, am I audible now?
Yes, sir. Yes, sir. Go ahead, sir.
Yeah. In a OPG, yes, it's little difficult to assess exactly whether it is buccally or lingually placed. In that case, we would be needing one more radiograph, probably an occlusal radiograph. So any two radiographs in perpendicular, which are taken in perpendicular to each other, can help. Otherwise, two IOPs. If you don't have accessibility for CBCT, two IOPs, like sir said, use slope technique. Take a normal IOP and then move your X-ray tube either mesially or distally and check for the tooth movement where it happens. So if it moves on the same side, it is lingual. If it moves on the opposite side, it is buccally placed. So these are the way to localize the object localization technique.
Sir, another question is, I think any of you can answer. It's like if there is a special child or a patient who has got a deformity who cannot stabilize their head for an OPG or even for a CBCT, what would you suggest for this patient?
Now, obviously, OPG would be much better because of the radiation dosage. You already saw the amount of the difference in the dosage. Like Sir said, Sir had put one particular slide wherein it said, even though the aim is to get a diagnosis, ALARA principle, wherein you want a diagnostically good image, even if it has some artifacts, even if some movement is there, the area of interest is covered, that is more than enough for you. In cases of special child, we need to consider those things and to go for OPG, wherein even if you repeat an image, the amount of exposure is much lower, which would really not affect any of the developing structures. Unlike CBCT, wherein if you repeat a CBCT, it's going to be a huge amount of radiation exposure again to the patient. So better to try out for an OPG if possible. Surely not a CBCT.
Okay, sir, there's anything like that you can sedate the child and strap the child and take a CBCT, I mean OPG, is it possible? I don't know, I'm just asking you, sir.
Yeah, sir, not necessary for strapping. Like you said, yeah, mild sedation, and if patient become fairly cooperative with that, stabilization can be created by parents. Or at times in CBCT, we do have machines which are supine, like your CT machines. Not everywhere, but there are some machines which are supine, wherein patient can be comfortably made to sleep and we can take a CBCT. If that option is there, that's the best for such cases, wherein, like Sir said, we can strap up the patient and we can do it, or even sedate the patient and do it.
Okay, sir. Thank you so much. This is another, again, a technical question. I think Dr. Utkal might be best person to say that. It's a very simple question, but for a general dental practice, what is the basic difference between OPG and a CBCT?
Yeah, OPG, like you know, is a two-dimensional modality, whereas CBCT three-dimensional. The whole process is like in OPG, you just cover one particular region. You blur the region which is not needed. In the sense, even though skull has so many bones around it, you don't get all the bones in OPG, you just cover one particular slice. That's what I explained in the concept of tomography. The same tomography is used in CBCT also, but the image is derived as a volume, as a 3D, which later can be sliced also. So the advantage here is, one is you get a 3D image, and second thing is, in each direction, you can view the same 3D image, sectioning it in 3 different directions, whether it is axial, coronal, or sagittal. That's the huge difference between OPG and CBCT. And other things, you know, cost factor, and of course the radiation. Sir has told us in detail about those things.
Yes. Koshi sir, the question, sir, inferior alveolar nerve, how to decide that how far it impacted cases? So the question is how to decide how far the inferior alveolar nerve in an impacted case in an OPG.
Utkal, probably you will be better.
Yes, sure. The point is, firstly, before taking up this answer for this particular question, generally I would like to say that even though I myself deal with CBCTs a lot, in my presentation also I said that CBCT is only an modality of investigation. It is not a primary modality at all. So for any screening purposes, amongst the two-dimensional imaging, OPG would be the best, because IOPA, you can't take a full mouth IOPA. Again, radiation is much higher. So OPG, when you take and you end up seeing some pathology, or like in this particular case, you said impaction, just have a look. Is it closely approximated to the inferior alveolar nerve? The moment you see that there is enough bone space between the alveolar canal and the tooth, you don't have to refer for CBCT. But the moment you see that it is very closely in close proximity with the nerve, I would insist that that is an indication to go for CBCT. So that's where we say, where your two-dimensional imaging modality give you an idea regarding the diagnosis, but they're not going to give you a clear, exact value or number. That is when you should look at CBCT. So this is one such indication, because relying on OPG for the measurements is not very safe, especially in case of a nerve, because during surgery, if at all a damage happens to the nerve, that can lead to a long-term paresthesia for the patient. So like Sir said, Sir explained us various techniques with which I can even measure the expansion or magnification ratios. But still, when it is a nerve, we don't want to take a risk. when I got to know that it is very closely approximated, I would insist on going for a CVCT. If not for the whole mandible, you can specify the region and go wherein the radiation and cost both will not be too much high.
So it is like a clinical situation. You relate with the clinical situation, and you don't have to take a risk. On the left side, it is okay. Right side, if you find it is very closer to the nerve, you indicate CBCT for that section. The left
Exactly,
side, exactly, you can go and place the implant, and you can go ahead. That's a great value knowledge. See how we are making things very simple and ethical and professional way. Thank you so much for these two moderators and the speakers. We are coming into a great session now. Could you please explain again? Dr. Appu Morris is asking you, Koshi sir, could you please explain how the magnification ratio in an OPG is calculated?
How the magnification is calculated?
Yes, sir.
Okay, so generally what we do is, the standard diameter of a ball bearing in implantology, what they say is it is 5 millimeter. So you can get 5 millimeter diameter ball bearings from any cycle workshops. And then what you do is you can make an RPD and you can place in the indigenous region. And you should always place the ball bearing in the center of the ridge, and you expose the patient to an OPG. Now what you do is, the standard size of your ball bearing is 5 mm, and then you measure the image and you measure the diameter of the ball bearing that you get from the image, and then you divide this measured the measurement with 5 mm. So that is your magnification factor. So in reality, what you do is, to measure the bone height above a nerve, do you want me to share that screen again?
You can do, sir.
Oh, then it will explain better.
Yeah. So basically, you have to get that ball bearings, make it sterilized before keeping inside the patient mouth, and keep it always at the what I've learned at this point of time. Keep it the center of the ridge. So you should have modes and methods to keep at the center of the ridge. Isn't right, sir? You can go ahead, sir.
Can you see?
Yes, sir. Yes, sir. Done, sir. Done, sir.
Okay, so what you do is, you know that the diameter of the ball is 5 mm. In fact, now what you do is you measure the diameter of this ball in the image. So this is 6.4 now. So what you do is you divide this measured diameter, which is 6.4 by 5 millimeter, which is the actual diameter. So the magnification of this particular region is 1.28. So that's the magnification factor. Now what you do is you take a template and you write a plastic template sheet you keep it on the OPG. And now what you do is you draw the inferior canal. Now you measure the distance you have above the inferior canal to the alveolar crest, which is in the image, which is 15.5. So this is the magnification factor, 1.28. So you divide 15.5 by this magnification factor. Now you get the actual measurement, which is 12 millimeter, which is the height actually above the ridge. Like that, you take measurements of this region and the rest of the region, and you divide it by 1.28, which is the magnification factor of that particular region. And then this is how you get the actual, vertical height above the inferior nerve. And Dr. Utkal has just mentioned that even this is not, very accurate, but you'll get a fair idea of how much is there. And when you place an implant, you're supposed to keep your implant 2 millimeter to 4 millimeter above the inferior nerve. So, you can decide your implant length by calculating the magnification factor like this.
That is what, sir, if you find that it is like approximating or end to end, then I would say that you go for a CBCT in that area and identify it and confirm it and then go for a placement of implant rather than doing in a CBCT for entire.
Yes, yes, Dr. Joby. So if you want to exactly know the three-dimensionally, now what you can do is you can make an RPD, which is a radiographic stent. You can mix barium sulfate with acrylic and make a teeth out of that, and then you can make an RPD, and then you can send the patient for CBCT. Now we have got a measurement of this region, and then you send the patient for a sectional CBCT, so that will reduce the amount of radiation. So you don't need to take a full CBCT image because your area of interest is only here. Then you can ask for a sectional image, which will reduce the amount of radiation to the patient. So that is how you can justify sending the patient for a CBCT.
There's a question which has been come for both of you. The first thing is, what is the contraindication for OPG? And next is for Dr. Uttal sir, what is the contraindication for CBCT? So can you, Eldo sir, can you answer what is the contraindication for an OPG?
Contraindication probably would be, if you take, it's not an actual contraindication. If you take a, full mouth IOPA, one thing is that it is time consuming and the patient will find it very difficult to keep the sensor, especially in the mandibular regions. And when you have a tori, it is going to prevent the placement of the sensor, the RBG sensor in the jaws. So that is one time you can send a patient for OPG, and then the cost factor and the radiation factor.
Uttal sir, can you please highlight onto that?
Yeah. Contraindication for OPG, when you're looking for finer details, like when you're looking at a tooth for caries, proximal caries, we should never go for OPGs, even if it is multiple decay, because it may not be like dimensionally stable. It may not give exact idea whether the involvement of pulp is there or not, such things. And as far as contraindication for CBCT, clear and straightforward. Whenever your IOPA or OPG is serving the purpose, if you're getting the clear idea regarding the case, you don't have to go for CBCT. So primary contraindication is that unnecessary usage of CBCT, what we call it as CBCT abuse. Very recently, I was hearing to a radiologist from USA. He's an Indian, like alumni of SDM Dharwad. You're saying that as radiologists, one of the common problem we are finding or facing is in Western countries is that excessive use of CBCTs, even for the cases wherein it's not very useful diagnostic aid. They call it as CBCT abuse. So absolute contraindication, whenever you feel your IOPA or OPG is serving the purpose, don't go for CBCT. And for OPG, like I said, for finer details, if you want to look at a proximal caries, go for an IOPA or bite wing, surely not an OPG, something like that. When you look for smaller things, smaller radiographs, a greater picture, a screening radiograph, OPG, a detail of one particular pathological region, CBCT. That's how I can put it in simple words.
Very good.
Nice, sir. Thank you so much. One question from Abhijay Singh is that, is occlusal radiograph possible in third molar areas?
Yeah. Yes, little difficult for a general practitioner probably. Oral medicine people who have done it before, yes, they can. We can take classic occlusal radiograph wherein film has to go till the third molar. So when I said locating the impacted tooth, I meant for canine. It's much easier. Anterior region taking an occlusal is much easier. So I specified for canine region, not for third molar region. But it's not like it's impossible. We can take an occlusal radiograph for third molar region also.
Okay, one question from Dr. Fatima Kabaski is that, can we use regular OPG settings / lateral sub to take water view image or maxillary occlusal image by just changing the patient's head position in case of emergency situation, even if it is not very accurate, for example, in case of surgical exposure required for impacted canines?
Okay, I can read the question, long question there. Firstly, I would like to say that occlusal radiograph is done in a different machine. What we use for IOPA, that is the machine which we use. So no question of taking an occlusal radiograph in an OPG machine. Second thing, as far as OPG and lateral ceph is concerned, lateral ceph requires an additional attachment to an OPG machine. Even though the X-ray source remains the same, the sensor is an additional attachment. So if your machine has a lateral ceph attachment, that is when your skull radiograph comes into play. In the sense, here the doctor has asked about Waters view. So to take a Waters view, I would be requiring a skull radiograph sensor. So if my machine has both and lateral ceph, then surely I can take a Waters view in that. That is not from the OPG sensor, it is from the lateral ceph sensor. One thing. Second thing, Waters view, the need of Waters view, I don't know why doctor asked me this. It's primarily for assessing the sinus. It's also called as paranasal sinus view, right? So in that way, it may not be a routine requirement as far as you're impacted to any of the routine procedures are concerned. So in a clinical scenario, taking a Waters view is not a common procedure which would come across your day-to-day practice. But as far as occlusal radiograph is concerned, yes, you can take it with an IOPA machine. If you have a normal IOPA machine, that's more than enough. All you need to keep is an occlusion film, which would be like costing you around 70 to 80 rupees. You can use that film and take an occlusal radiograph. It helps a lot in locating canine impactions, whether it's buccally or palatally or lingually placed.
Thank you so much, sir. One more question, sir. Mr. Asaya, is it possible to take a coronal or sagittal section on OPG machine?
No. There's no question of any sections in OPG. All we can get is what we call it as panoramic view. I cannot put panoramic view under any of the other sections. It's neither an axial, neither a coronal, nor a sagittal. It's like if you have attended my previous class, I had cut the apple into different chops. If I peel the apple from front to back, that is when you get an OPG. It's a different section which cannot give you neither coronal or sagittal views.
So thank you so much, both the amazing lectures, sir. Eldokoshi, sir, your session is amazing. So simple way you have explained. It's all the groups, all the chat boxes filled with the excellent session, simple way, amazing collection of OPG cases that you have. That's an amazing, sir. And many people asking one thing, sir, can you be a little more, so, you know, the measurement? I think we need a hands-on session of that ball bearing. We can give to all candidates so they can get those ball bearings and they keep on to a styrofoam and all those things. We can plan for a hands-on session, a full day session for an OPG, sir. If you are free to that, people who are interested, please let us know. I think it's required. The way that's are explained, we can give you styrofoam. In the styrofoam, you can do the markings and OPG and whatever the ED radiographic errors that you are telling, you can literally see it and do it. We plan for that. And Utkal sir, people are asking for CBCT, how to measure bone height in anterior segment, posterior segment. They are the happy news for everybody who are listening to us that in this month end, Utkal sir is going to come with a 4+3 hour session, 7-hour session of live CBCT, extensive CBCT session. He's going to cover with live video demonstration followed by hands-on. Oh, hands-on, is it possible? Yes, with CBCT is possible. He's going to give you Caristream software, install in your laptop or your mobile, and he's going to give you some 4 to 5 cases, and each cases how he's doing and coming into a diagnosis, he's going to teach you. But very few seats for the last 2 to 3 hours. Sir told I cannot teach more than 10. So the last hands-on live demonstration is only for 10 people, not more than that. He said very clearly, because he had done for 60 people in my college. I was there. I was a scientific session chairman there. He said, sir, it is not possible. And he had a lot of hiccups there. So this time he said only 10 people who are interested come, otherwise please not there. So it's going to be a one kind of session where you are going to get a software of CBCT for free, and you can upload your own patients whom you want implant planning, third molar impaction, root canal, accessory failures are there. You upload it. Sir is going to guide you. how to identify that accessory canal, that pathology, that implant, that uh, uh, third molar, which how you approach that. So it's a unique session which sir is going to do it. And with that, I just invite.
Last word from my side, sir. I should really thank Koshi sir for this extensive case display and basic clinical perspective of OPG. Even if I had to speak about OPG, I think I would have gone into more of theories. I would have used a few terms which may not be very familiar to all the clinicians. I would really want to say that sir made it much easier than a professional radiologist, because when we try, we always put in some theory, which clinicians may not require up to the level. And very neatly, sir explained when to use OPG and when not to use CBCT. A very important aspect, unnecessary exposure is not acceptable. Even if I myself have an CBCT center, I don't really accept that part. And lastly, we need to appreciate sir's depth knowledge of implantology, because it was not just an OPG session. I felt it's like 50% of implantology also was being taught to me, that too without using a CBCT. It was like people who don't have access for CBCT, how can they do implantology? That was one thing which was highlighted in this particular session. I felt using CBCT and doing implant is much easier, I would like to say, sir, with surgical guides, which all the virtual implants we place and give it. But you taught us like how it can be done even without. Probably 5 years or 10 years back, how you people have practiced implantology, same thing. So the people who don't have access for CBCT have to follow what sir said and go ahead to place a proper implant so that the success rate increases for you all and your practices. So wonderful session from you, sir, emphasizing clinical perspective of OPG and implant part. I really loved it, and thanks a lot for that wonderful session for last 1.5 hours.
Thank you, Dr. Utkel, for your wonderful words. And I should tell the group here now, I have not seen Utkel at all in my life. Last week only, I was listening to him, and it was so impressive a lecture. And thanks for coming with all your knowledge and supporting me in this presentation.
My pleasure, sir, and thanks to Online Dentistry, of course, for the opportunity.
Exactly, sir. Exactly, sir. You made it so simple. That film of OPG, which we used to see for canine impaction, crowding, you made it so simple. And that implant planning, which you mentioned, was an amazing thing that you have done. That even our conventional methodology have some value, and that is the stepping stone. And then you go into the next level, sir. Salute to the way that you presented and the cases. And I can see the chat box, the number of cases that you have shown and your experience you opened up. It's a new thing that we should look into that. Next time OPG, we definitely see that condyle, that ramus area, that bony calcification which you told. We will definitely look into that. Thank you so much, Eldokoshi sir, for opening up your amazing value of knowledge. Thank you so much, Uttal sir. Thank you so much for being here. And
Thank you.
All the participants. We had around 450 participants for today, and your certificate of participation is available in our website www.onlinedentistry.in. You have to register. You can get the certificate of participation of this today's session, and we are going to come up with more clinically oriented topic next Sunday at this time, 8 p.m. Do not miss unconscious patient in your practice. How to manage clinical tips and tricks. Be with us, stay with us, refer to your friends, go to our YouTube channel, Online Dentistry. Please do subscribe the channel. Please put the bell icon so that you get all notifications anytime you get the upload previous sessions which has been happening. So if you put subscribe and if you put the bell icon, you will get the notification of our old presentation on demand. When they ask, we upload in our website, and you will get the notification only if you subscribe our YouTube channel and put the bell icon so that you get a notification and you can watch freely at your leisure time. Thank you so much. Good night, and hope to see you soon. Stay safe, stay home, and let's say and pray with folded hands this pandemic gets over. As a fraternity of healthcare, let us do the best at this point of time. Good night to all of you.